counties in July. The major responsibility of that is to show the flag of counties at every state association around the country.
Wow.
I will probably hit all 50 states during my presidential year.
Wow.
And we'll have a chance to have a presidential initiative, which I have selected to be the county's role in poverty reduction in America. And we intend to target breaking the generational cycle of poverty by focusing on childhood poverty and early childhood education, especially in that 0 to 3-year-old space where there is nothing happening.
Yeah.
Basically.
Well, that's outstanding.
I will be here when I can. I keep up with the materials and where we are. I have to trust Commissioner Wynn to keep the discussion somewhere between where he is and where I am.
Which only a foot.
Well,
We're
Commissioner,
not
that's a
as
big
far
deal.
apart as he would like to be.
That's a big deal, so
Yeah.
congratulations.
Yes,
to
definitely.
Yes.
Yeah.
We're very proud of you.
Thank you.
Yes. Yeah. Thank you for letting us know about that, Roy. Okay, so GK, was there something that you wanted to? I noticed you're on the first part of the.
Yes, first of all, I was unable to attend your last meeting, and I apologize for that, but I understand there was some discussion that occurred on a couple of things, and just wanted to maybe clarify some issues and make sure that we understand some of how we've approached some of these areas. First of all, and I think, Mark, you might have been the one who brought up the issue as far as the work that Cumming is doing. Cumming is doing the evaluation of the facilities, and there was work done at the hospital district both in 2010 and 2014 as related to facilities. And one of Cumming's responsibilities was to evaluate and review that material along with developing a plan, if you will, as far as an evaluation of existing facilities and their worthiness of being able to deliver the type of health care that we're expecting within the next couple of. Am I hearing music?
I was getting ready to say, is that mine? No, you know my secret.
I told you
I sure like Marvin Gaye, and I do.
You didn't know how close. Now you do.
I would tell you, you all start getting up and dancing.
No, I don't have a partner for that.
And I will not say that was my first wife calling.
Tell her the check's in the mail.
Actually, that's why Channel 8 wanted to come here. Is they heard there was going to be a big dancing thing. Uh-oh.
So anyway, I wanted to clarify that part of Cumming responsibility is to evaluate those past documents. In fact, we made those documents available to Cumming as soon as they came on board. In fact, they reviewed those prior to coming on board. So it's a continuation of that evaluation plus a hard look at existing facilities to determine the feasibility of using them in the future. Also, the internal equipment that's in the facilities and the worthiness of the computer systems and things like that. So there will be some discussion of past activities, but there's also some futuristic views also. The second item was, I believe that there might have been a mention as far as the dollar amount or the amount of people that we treat from out of county. Mm-hmm. And I'd like to focus on the emergency room. It's a regional trauma center. So if people are injured severely, they will most likely come to JPS. most of those injuries happen through automobile accidents and things such as that. There are other situations that they'll come also. But the payer mix that we see with people involved in auto accidents, normally there's an insurance policy that provides the medical treatment for those individuals, and Peter Smith basically gets their money back. The money that they expend is covered by insurance. So there's also a fund that the state has. It's about $55 million, and it is shared by all emergency hospitals, their emergency rooms, as it relates to uncompensated care for people who enter our trauma centers. Now, the good news is that there's about $55 million in that account. We get less than $1 million because a lot of that goes to the more rural areas of the state. Second of all, the fee that is collected is kind of interesting, and thank goodness we have our legislature. They take half of it and to balance the budget, so we get half of those numbers. So, but quite frankly, we will take any money that we can get because that helps our taxpayers. So I did want to clarify that particular issue, and I believe that might be it. I think, was there a question maybe about the community health center that we have in Azle? It's pretty far up in that part of the county.
Azle?
Yeah. Let me just make a comment.
I don't recall. Yeah.
Yeah, let me make a comment about that. What we try to do whenever we locate, the issue with 199 is that the lake cuts off that part of the county from the rest of the county, quite frankly. And so our clinics are situated in population centers. Azle is the one. And so we're seeing now a substantial amount of growth that's coming out of Fort Worth and Lake Worth, moving into that direction, that's going to be utilizing that particular facility. And normally the people that use that facility are connections people. And and remember that connections people, one of their requirements is that they have to be a resident of Tarrant County. We also see people maybe from other counties, but when we see them, we attempt to collect a fee, and it's either insurance, which we see some of, or we simply go and ask that they full pay. And so while there may be a concern that there's a clinic that is far northwest, really I congratulate the hospital district board for seeing that as a potential growth area, and it met their expectations. So if there was a question as related to that, then that's why that clinic was up there. Plus, I believe that Azle gave us property to put that clinic on there too.
Yeah, and that was one of the 4 or 5 original clinics in the system. It's one of our older facilities.
So, but I did want to clarify those issues. Like I said, I apologize for not being here the last time. And Mr. Chairman, I think that's clarifications.
Okay. Thank you, GK. We appreciate that. I must be early dementia. I do not remember the dialogue on the Azle clinic.
We talked about it at staff, and my staff is pretty perceptive.
There was a discussion about it. Remember the number 1 recommendation?
Yeah.
On top of that list?
Yeah, I don't remember it being controversial. The only thing I remember was some question about the Burleson Clinic because it's on the line of Johnson County and Tarrant County, and how do we factor all that into our planning and so forth. But I think wherever your clinics are located, we're always going to have some folks that are going to be coming from outside Tarrant County. It's just the way it works, and there's no way you can put up a wall saying we don't take you here. I mean, it just doesn't work. We're into building walls. We're in building. I know. Okay, I'm not going to get political here. So
Better move on.
That's right. Let's keep going.
Chairman.
All right.
Chairman, Channel 8 is behind you.
Oh, that's right. Oh, was that on? Oh, see, it's going to be on tonight. Here we go. Okay, so how about Lori and Greg? Are you guys ready to go?
Yeah. So I'm Lori Weisselberg from Health Management Associates, and Dr. Greg Vachon is here to present with me. I'm going to go through about half of the slides, and then he'll pick up and finish off. So we thought it would be helpful to do overall recommendations. You've been seeing people from our firm come in every couple of weeks and kind of drill down pretty deeply on certain chapters. But we thought we'd kind of take a step back and say, kind of overall, what have we completed? What have we accomplished? So I want to start with the beginning and say in August 2016, and yeah, it's almost been a year, the Tarrant County Commissioners Court contracted with HMA to prepare a final report entitled Long Range Planning and Analysis for the Tarrant County Hospital District, or JPS Health Network. And we just submitted that. We submitted that last week, so many of you might have that in your very large binder. And there's also a supplemental report on behavioral health. One of our recommendations, and I'll talk about that in a minute, is to have JPS and the county really do some long-range planning around behavioral health infrastructure for the county. And that document will really help jumpstart that effort, should it be undertaken. So the charter for our work was that with assistance from JPS Health Network, that we would look into the future to anticipate changes not only in population and demographics, but also in technology and delivery system, and take that information and take a look at existing plans for the future and determine whether they were on target or maybe needed a little adjustment. So with the overall purpose of making sure that the Commissioners Court was fully informed in making decisions going forward in supporting JPS and its changes. So our approach, we conducted research, we engaged stakeholders, and they were individuals, they were community forums, there were focus groups. We developed findings, we provided recommendations for action, organized in several focus areas that form the chapters of the report. So there are 8 chapters in the report. We do have an executive summary, so I think focusing on that will be helpful because the report is quite long. So the first one, and we've done presentations on all of these. Some of them were combined. We did 4 meetings. So voices of the community, so you get a real good sense of what people have been saying about JPS and its future. Macro trends in the United States healthcare delivery system, what kinds of changes are happening that we need to be aware of as we make future plans. A community health needs assessment that looked not only at health status and demographics, but also population projections. We looked at system capacity, your current capacity, what you can absorb, and population needs in the next 10, 20 years. We did a market assessment related to medical staff and medical education. We looked at the JPS delivery system a little bit more operationally, including major service lines and JPS strategic plans, and conducted a SWOT analysis related to those plans. We looked also at Tarrant County Public Health, and Vinny's here with us today. Looked at the role and relationship of public health and the JPS Health Network. And then we looked at financial perspectives, and Ray was here last time to present on that and drill down a little bit to give you some information on how JPS is doing financially compared with others. So what are our key findings? Basically, the JPS Health Network is a really strong academic public hospital system that provides a very large proportion of the safety net care in Tarrant County. We were pretty overwhelmed with positive sentiment about the network. We found that JPS, in the eyes of the county, is critical to the county and is recognized and valued not only by residents, but by public health, by social services, and other hospitals, very critical to other hospitals and healthcare providers.
Lori, can you go back to that first slide?
Yeah.
For the sake of, for the benefit of those who are unable to attend these meetings,
Yeah.
and especially those who don't have the time to read the 250-plus page report,
Yes.
maybe we should consider clarify what you mean by very large, right? Because I did some digging into the report, and I came to the realization how you came up with that conclusion.
Yeah.
because you basically took the numbers of cases of the uninsured and the Medicaid patient in
That's
2016 in Tarrant County.
Right.
You came up with a total number of cases of about 60,000, and JPS handle about 55% of those cases, right?
55% of discharges.
Of
for
discharge,
market share,
of
so for
discharges, right?
inpatient,
So
yes.
the other 45% came from the other hospitals.
Right, spread around the
So that's
county
how you
and
came up with
hospitals.
that proportion,
Right.
right? But another perspective from that is combined of the 100%, 55% JPS, the other 45%. Of the 55% of JPS, that's only equate to 26% of the overall total need of the 250% or less population. So even though you look at it from that perspective, from this perspective that you said up here, 50% is a large proportion. But when you're comparing that 50% to the total need, it only equates to 26%. So maybe it's a clarification. I think it's important that the decision makers
Yeah,
understand that.
right.
Okay, even though we're doing a very good job in taking care of the safety net, but in the larger scheme of things, we still have a lot of room to go.
That's true.
Right. And another perspective, if you take the $350 million or so that we collect from the property tax and divide it by the 35,000 discharges that you are looking at or so, it costs the county JPS is spending about $10,000 per indigent discharge from that standpoint, right? So I'm not sure if, without any point of reference, I'm not sure if we are doing a good job or a bad job. 26% and $10,000 per indigent discharge, is that good or bad? Is that average? Because we don't have any numbers to compare to. So perhaps you can shed some intelligence on that.
Yeah, I think for a single entity, you are providing a very large amount of safety net care for the county. You have many hospitals in the county, some of which are safety net hospitals as well. I don't know, Greg, if you have any thoughts to...
I would agree with your sentiment and what you're saying, that, and what you said, which is that it's a large proportion of a need that's not being fully met. So you're exactly right. The need
Right.
isn't being.
Yeah, my point is, without sitting down and read the 250-plus page report, you won't gain the perspective. So if you put together these PowerPoints and present it to the decision makers, the policy makers, I would ask that you clarify that first point.
Absolutely.
Because very large means what?
Right, and there's
Right.
another report that's coming, right? A report that pulls on priorities that you see as a citizens board, and priorities from, and data from Cumming, the other vendor, so that you have a report to present, and whatever you want to emphasize is what we'll emphasize. We're writing on your behalf.
Okay.
Yeah.
I want to make a suggestion just going forward. It may be good if we see a comparison between Tarrant County and other urban counties, so that we can gauge how well or not we're doing. Hopefully, we're doing well. But for example, how are we doing in regard to Harris County? How are we doing in regard to Bexar County? So then we'll know. You understand what I'm saying, guys? We'll have
Trying to get a reference
We'll have some
point.
apples to apples, oranges to oranges.
Sure.
To compare. So then that way we will be able to gauge what you're talking about. I agree with you.
And some of that is in the community health needs assessment, and reflected in different parts of the report, showing that, for instance, the number of emergency room departments or later stage cancer. So some of those kind of things are showing that the need, which is large and not being met, is in fact having some downstream consequences. And I hear what your point is. How does that compare to others? But the community health needs assessment does compare that to others around the country.
Right. And then the other issue is ambulatory, right? You're just talking about hospital admissions and the need to invest in the ambulatory structure to prevent some of those hospitalizations and how important that is. and that you're covering a certain percentage, and it's about a quarter in primary care and in behavioral health. It's also lacking. So those are decisions that the county needs to make. It's political, it's finance, it's all sorts of things that come to bear on that decision. But, you know, are you satisfied with maintaining the status quo of caring for 26% of the primary care for, you know, the indigent? So,
Can I ask you one other question related to that?
Yes.
Back on page 2 of your slides. I think this is what you're talking about, but I'm trying to understand what that last sentence means in that improve the health status of the county. What does that actually mean? I'm not quite sure what that was intended to mean.
that was a charter that came from the Commissioner's Court to us. And so...
What did you interpret it to mean then? I'm still not sure what that means.
Yeah, so we interpret it to mean a balanced healthcare system. So not one that's just there to catch people as they fall, right, in illness, but one that keeps people healthy and promotes health and prevention as
Does
well.
that mean capture 100% of the citizens, 50%? I mean, I'm still not clear about what you're trying to improve.
No.
And health status meaning the outcomes of the population. That, you know, some of those things are the community health needs assessment, rates of, you know, big picture items like rates of smoking or late stage cancers that I just talked about, non-acute emergency room visits. Those are kind of some of the markers of health status of the population.
Preventing and managing chronic conditions like diabetes. So it wasn't just a sole focus on, are we building a tower, how big is it, you know, that kind of thing. So looking more broadly at health outcomes for the population. Does that make sense?
Maybe it'll be explained as we go through. It sounds a little generic to me. I'm just trying to focus down on what we're going to get to in specific recommendations.
You know, to piggyback on what everyone said, I think, Commissioner, you raised a good point. We've got to know where we are now with that 26%. Are we good with that? But on top of all of that is our county growing. And as we grow, how can we accommodate? And I think it kind of piggybacks into what you're saying. If we're talking about improving the health status, we've got growth going on that we've got to be able to manage in some kind of significant way.
Exactly, nice segue into this next slide, which is demographics are changing. So the county's population is expected to grow over 46% in the next 20 years, so from 2 million now to almost 3 million in 2037. Medicare eligible population is expected to increase sharply, about 41% in just the 6 years between 2015 and 21. The population will grow increasingly diverse. Highest growth rates are in Hispanic, Asian, and African American populations. So you're absolutely right. The rapid growth, the aging, the diversity of the Tarrant County population in the coming decades, and changes in the delivery system that we talked about, what's happening nationally, as well as the financing environment, requires JPS and others to focus on several priorities simultaneously. So the rest of our presentation is really...
Speak to Dee's question. That whole concept of improving the health status of Tarrant County is a macro goal. And it is something that cannot be accomplished by John Peter Smith Health Network by itself. First of all, people have to adopt responsibility for their own health care status and have to make decisions about their lifestyles and other things that will support good health. But also, John Peter Smith has to work with the other healthcare institutions in this county, including the Public Health Department, which is an outward-facing organization. They're supposed to go out in the community and promote good health and teach good health and measure good health. Whereas hospitals traditionally have just kind of waited for sick people to present and done what was necessary to get them back into the community. The system is too fragmented as it is to support community health. We need to be looking at how we're going to integrate JPS with all of these other healthcare institutions, and every one of them has a part to play in improving the health status of the people of Tarrant County. It's not something that this bond program or the restructuring of JPS is going to accomplish by itself.
Yeah, and you bring up an excellent point about integration, and JPS is not just a hospital, as we know. It's a health and hospital system, and affecting one part of it affects the other. So the more you invest in outpatient and ambulatory and prevention, the fewer number of hospital beds for psychiatric, for medical inpatient you're going to need. So it's a balancing, but then it's also integrating further in the community. With public health, with social service, with other hospitals, bartering with other hospitals. So it's a little complicated. That's why the report's so long. Okay, so we talked about the burgeoning population, and so a key priority is to ensure an adequate workforce, right? So by expanding and strengthening JPS's health professions training programs. Public hospitals that don't have teaching programs or properly invest in those programs are really not sustainable. You're going to need that workforce. We have a lot of specific recommendations related to that. Recommendations related to ambulatory care. So other critical priorities include expanding that ambulatory care in communities of greatest need. And Sam from Cumming was here at your last meeting and talked about additional primary care medical homes and proposed what they would be and where those would be. Also diversion programs as we look at hospitals. So inpatient diversion, criminal justice diversion of people with behavioral health issues, integrating behavioral health services into existing medical homes, into newly planned medical homes are really important. Any specialty behavioral health and substance abuse services, we find that those are not as robust as they might best be in this community. And psychiatric evaluation centers or crisis support services. Those are very concentrated centrally and really need to be in outlying areas of the county as well. And again, there's a whole behavioral health report that speaks to that and justifies that. The next is addressing anticipated shortages in specialty care. And when Greg was here last time, he talked quite a bit about that and what specialties are most in demand and lowest capacity. But partnerships with other provider organizations, strong recruitment efforts around those areas are really, really important at this point as well. Okay. I'm just going to take over with inpatient.
All right. Thank you. Dr. Greg Vachon, we've met before, and I'm taking over here on one piece, a kind of meaty piece, the acute care, the medical beds, so the non-psychiatric beds, and the numbers that would make sense. There are different ways to drill down to a number and what might make sense. This is one way, extrapolating from the report with the number of beds and the amount of need that is currently fulfilled for the JPS connection population, and extrapolating that to the future with some pretty aggressive reductions in the lengths of stay and the amount of admissions. So this really assumes kind of a Some of the other things that we'll talk about: population health management, primary care, care transitions coming out of the hospitals, things to reduce 1% per year, which is quite a bit, and to think about where you are as a county compared to others. You're about in the 50th percentile, if you look at Dartmouth Atlas, in terms of number of beds per population. This would get you down to the 10% range, so kind of those highly managed parts of the country with a pretty tight number coming about over 20 years, so it would take some time. But with those assumptions, it's a need of 594 beds. If we take an earlier assumption from earlier report, Blue Cottage, which was really about length of stay, so kind of efficiency within the hospital. So there's more control there than at a population level with admissions. It's more about efficiency in the hospital and length of stay reductions. Then that bed count would be, extrapolating again from the JPS connection population, 664 beds. So you kind of get a range there. And there are some other ways to triangulate around a number. And some of those, come at it from an angle of what is your current market share, and different ones that Patrick may talk about. Other ways of kind of narrowing down on that number. But that's kind of a range there when we look at fulfilling the same population need, which is 34%, specific for the JPS connection population, 26% for the broader. Since that, population need is relatively low, right, 34% for the JPS connection, and since we have later recommendations here to really pursue some improvements in the payer mix in terms of recruiting Medicare and building geriatrics and doing things that are building capacity in other areas, and the need is already low. For those two reasons, we think it would be reasonable to accelerate the shell space, in other words, to move forward more quickly with building the whole set of beds.
Question.
Sure.
This 34% that you reference up here, current population percentage, 34%. Mm-hmm. Is that 34% the total universe of eligible JPS connection patients, or is it the percentage of that population that we're currently serving?
It's the whole eligible universe and what it will be in the future as it grows.
So you're extrapolating that 34% of the total population will be JPS connection eligible in 20 years?
Not exactly. That of the JPS connection eligible population that there will be, you'll be serving about the same need as now, which is 34% of the need of that population. So there's a population need that you're serving now. It's 34%. You will be in the future. This is the assumptions made, kind of serving the same percentage of that population need, and that's where you get the.
Currently, it says it's 26%, and our goal is to move it to 34.
So on the JPS connection specific, it's 34. On the overall indigent population, it's 26%. So this gets, but that's on the primary care side as well, where when we focus right down into that population, the needs are.
That begs the question: is that 34% the right number, or is it something that we just defaulted to because that's all the capacity that we have?
Yes. It is bringing forward kind of your current commitment to a future state, and not only that, but assuming some pretty aggressive reductions in the overall population admission and length of stay. So having that bed growth controlled through other mechanisms. But you're right. It does assume a particular kind of level of commitment that's brought forward.
But does that 34% represent the proper level of commitment? Or do we need to be doing more or less? I mean, that 34% is just a default.
Agreed. It's coming to a place as a system of care and as a county that you have historically brought yourself to, reflecting
So why
decisions.
extrapolate that into what we should be doing in 20 years? We ought to be trying to figure out whether that 34% is really where we ought to be in 20 years.
Commissioner, is money related? Because
Sure.
34% of 2 million is X, 34% of 3 million is X plus. We are assuming by maintaining a 34% ratio of a bigger population, we are basically increasing the capacity to serve that same 34% of a bigger number. So in order to go above the 34%, we're going to have to pump in a whole lot more money.
We're
do
going to
that.
have to pump in a whole lot of money just to remain.
Just to remain at 34%.
Yeah.
That's right.
Right. I think that's exactly right.
Say, Greg, let me ask you a question. You have a couple of times said today about the 1% reduction in length of stay and emissions, and you always preface that with a very aggressive program.
Well,
which
it gets you
gets
it gets you to a position that's best in country now. So systems of care that are
So I guess I kind of figured that's where you were going with that. So is there going to be at some point a discussion on what's going to be probably a very multi-point process to achieve a very high goal? Because I'm not sure we all know exactly, including myself, what it's going to take to get to that very aggressive number. Because that's a critical number throughout all of this in terms of need. So is that part of the future presentation?
It's part of this, and it is around population health management, care management, payment systems, which in fact, in some ways, the JPS connection is that type of system already, where there is, some bearing of risk on the part of the county for the care of that set of population. But certainly, advanced payment reform is part of achieving that.
Yeah.
And then the care delivery system that's organized around achieving that.
So I think it would be good for us to kind of know just how daunting that task is going to be.
Okay. Yep.
Since it's a critical part of your
Let's
numbers.
hit some of those, and then
I just
maybe
keep
have
getting
some
worried every
questions.
time you say this is a very aggressive.
Yeah.
Because
there's
so many
points.
parts to it.
There is, yeah.
And I don't know that this committee can attack all those parts.
There are. And so the 664 is really looking more at JPS and length of stay and kind of controlling inside the four walls and the costs and the time. The lower number is really setting up care management systems that are and population-based and health information exchange between health systems, pieces that require going beyond the four walls.
Yeah. Okay.
But primary care and specialty care as well. The next piece is the psychiatry. And if we recall, there is a estimation here that's based on a literature published kind of number, which is 70 public beds per 100,000 people. And that we are assuming together with the right kind of infrastructure, an integrated behavioral health system that includes not only JPS but others, that can be cut in half. That really you can go about really creating a system that cuts these needs, these far future needs, in half. And then further saying JPS is not going to be able, in that future system that's integrated, JPS is not going to be able to do all of, meet all of those needs, that it will be 50% of that need. So in that kind of assumption, that's where the 516 beds come from. That's how we get to that number. The 132 beds available fills 26% of that Remember, 50% really kind of managed down to a lower number, and then fulfilling 50% of that need. To remain at the current 37%, so that's kind of where the fulfillment of psychiatric bed needs for the population would be, you'd need 60 beds just to stay at that current level. So that at least gives you the current level. This is getting to your point of what would it take, right, to get to these numbers, to kind of manage the reduction in need. And part of it is preparing for, you need an environment also that's kind of meeting you on the other side, but preparing for value-based reimbursement and risk-based managed care, where you have responsibility for a financial and clinical quality responsibility for a population of patients. In order to do that, you want to have primary care, a robust primary care that has panels of patients where that primary care practice knows they're taking care of this 1,500 patients for a particular team, primary care team, or a health center that's typically going to be taking care of somewhere in the range of 10 to 20,000 patients. And they are managing them prospectively and proactively. And then using information technology and data management really to exchange information and to use that information to manage the population over time. And lastly, enrolling those high-risk patients into care management. So those that need additional attention because they've had a utilization event, they've been in the emergency room, or they've been in the hospital, that they're identified and given more resources to prevent future avoidable utilization. This goes along with something that come up in all the stakeholders. It came up here in this meeting earlier, which is that the community as a whole does need additional behavioral health capacity. And because you are serving the largest proportion of that in terms of inpatient, and you have a robust and really, as Karen said when she was here, a really great system of psychiatric care, not so much on the substance abuse, but on the psychiatric care, that you're in a position to lead that as a JPS as an institution is in a position to lead that integrated behavioral health system formation. So these are kind of service lines or places that when we look at the population and the population growth in the future, that makes sense to have some focus on. And another one of those is cancer care. People are living longer with cancer, and your population is aging, and you have a good, very great system for delivering cancer care now. And because of that aging population and the later recommendation coming up around payer mix and trying to increase Medicare, continuing the geriatric focus and growing that over time would make sense. This Lori was talking about, and Commissioner Brooks, that shifting from just sick care to the health of communities. Now, this is not alone as JPS itself, but rather in partnering with public health and others in order to have a focus that's beyond sick care. And that's really connecting with social services, connecting with public health, and addressing social determinants of health like transportation, other pieces that affect people's health. On the payer mix, as in many public health institutions, you do serve more of uninsured and Medicaid, and that's good. That's a mission. That's what you're about, and that is a large amount, that 55%. So no doubt that is large, and it is a current commitment. But over time, to kind of maintain the financial strength of JPS to be continuing to wrestle with that and be able to attract, retain Medicare and commercial as well on the exchange side. This you heard from Ray in terms of your three major revenue streams, and you know the idea is that some of those, like the supplemental Medicaid funding, are they should be there. There's a reason they're there, and hopefully they will continue to be. But to have that be a smaller piece of the overall puzzle would be good. Excellent. And then finally, having facilities that really meet the standards of today. That's things like single person rooms that are kind of meeting safety standards as well as expectations of the market. Will allow JPS both to attract and retain patients, but also on the physician and education recruitment side.
I think it's important, of all the things you've shared, to go back 2 slides and look at the fact that JPS, right there, the net patient service revenues is greater than property tax revenue. For all the issues I've heard with people who are less than pleased that we're about to ask for a bond issue over taxes and whatever, this hospital continues to supersede with net patient service revenues what the property tax revenues is. That's a positive. I think we could do better in that regard if these standards of care and people, the comment of, hey, I just want to go to JPS. Now, the other thing I'm going to toss in, and I'll be through, is there is, with reference to Dr. Flynn, the stuff about we're going to get some medical students and we're going to get some residents and they're going to train here and they're going to stay here. There is no aggrandizing in our healthcare system for primary care docs who say, I want to be on the backside of shortening these length of stays. I want to be out there in the grassroots when these people get dismissed from the hospital, and I want to make a difference in keeping them healthy. That hasn't been emphasized that I've seen in medical education much. You guys referenced the systems that are real successful. The ones that do really well, there's a connect about, you're going to see Dr. X on April the 3rd and this and that. I don't know that we have that part of that done either. So, in essence, I'll finish by saying I think we started, and we're working right now on an assembly line with the 57 Chevy that we're not trying to make into, whatever, a 2017 Chevrolet. While it's moving, while the radio's playing and we're traveling down the road in it, we're trying to make it better. It's not going to be easy, but my goodness, it's time to do something. How much is for us to help decide. But to me, I think it's remarkable that our net patient service revenues do supersede property tax. If somebody wants to fuss with you about taxes, because I'm an advocate for this, I really am, I think that's a real plus. I really do.
Yeah. And you have an incredibly strong family medicine training program that does have that in the curriculum, and so I think those people are coming up.
I just want to clarify. So are you saying once someone is discharged from the hospital, that the county hospital will have some system following up with them to say, Ms. Jones, we know that you're a diabetic and you need to making sure, especially, okay.
Right, our family's been in the hospital last year. My wife and I have both been in the hospital. Have you ever been discharged from a hospital lately and tried to figure out what comes next? 2 things. I'm here, and in an hour I'd like to be home having dinner. And number 2, I haven't a clue who I'm going to see and what. And some places do a really good job, and some places don't do a very good job of first getting you out the door. And then the major flaw with our value-based care system is, what's the worst thing we want to see in this system? It's anybody that bounces back in 90 days, because guess what? You look like, as a patient, you look like a bad actor because you didn't take care of yourself. So there are some key things in this that I think on the hospital system side we have to take care of to identify to the commissioners that, hey, we're doing our job. But I think we have some things to really hang our hat on.
Yeah.
I mean, if we were at 60% of our revenue was only from the tax dollars, we'd be in a heck of a mess.
So JPS is investing in a care management program.
Yes.
So it's getting stronger. They just hired a head of care management, and there are more people in the ambulatory sites to do that work and follow
Lori,
up with
Lori,
patients.
use your mic so everyone
Oh.
can hear you.
Oh, yeah, you just got to turn it on.
Yeah, I just wanted to make the point that this isn't foreign to JPS, that they are doing this work and they are planning to do more of it.
Yeah. But, yeah, agree, that's a...
But the real
How-
question is, can we make that investment? That's a significant investment, commissioners, isn't it, money-wise?
Well, it's a very touchy subject, and and I think it's important that we be frank about it. Property tax alone isn't enough to fund the care for the indigent population alone, leave alone the others. So we need to have a good mixture of revenue sources. And frankly, part of that must come from the net patient service revenues, whether it's insurance or cash payment or whatever, right? And so in order to sustain a healthy JPS financially, we need to have a healthy mix of revenues. What is that mix? What is the ratio of that mix? It's quite tricky to figure that out, because if we lean too far and too fast toward the net patient service revenue, there'll be other organizations, healthcare organizations that is, in Canton County that may not like that. Okay, they view that as JPS competing. Okay, and that is a factual dynamic that we have to be sensitive to.
But it does help us long-term, though.
Absolutely.
If people, less hospital visits, that's what, I remember I took my cousin out of a rehab center about a month ago, and the next day when I got her to my home, we received a phone call from a healthcare company that said, my job, the rehab center told us to call you, but their number one job is to keep her out of the hospital, which was a good thing. So that to me, that resonated with me and with her, because we didn't want her in the hospital. She didn't want to be in the hospital. But that would be, in my mind's eye, I can see how that would really be helpful to people.
Now, Co-Chair, let me make one point, and I think Dr. Lowry hit on it too. A lot of what you're hearing, we do this. We do make follow-up appointments after discharge. We do make follow-up from emergency department discharge. Diana, I don't know if you're the person to ask, or maybe Karen, but could someone just give us a brief snippet on our procedures relative to notification of patients after discharge? Because there may be a misconception here about what we do and what we don't do.
Yeah, my name's Diana Brainsel, and I'm the Senior Vice President for Community Health. Thank you, sir, at JPS.
There's Michael.
Oh, thanks, okay, thank you. So I will tell you a little bit about what we're doing today, and while we are not perfect, we do a pretty darn good job. More than 70% of our patients, as they're leaving the hospital, do have an appointment in the appropriate place. Please remember that some patients still today, when we talk about wellness, don't identify with the primary care provider. They don't have one because they've never had to go, they haven't been sick. But 70% of our patients, a little bit more than that, leaving the hospital actually have an appointment at the next appropriate place of care. It's either their primary care provider, our post-hospital discharge clinic. So if a patient doesn't identify with the primary care provider but is going to need to be seen in a week or so after discharge, we have a clinic for those patients. Or specialty care. So if I'm a trauma patient and I've got a broken leg, the next place I might need to be seen is with that orthopedic surgeon. So we do work on that. We do have a case management program in our medical homes. So we have case managers in all of those medical homes. And a part of what they follow is a list every day of patients who are leaving the hospital. And their job is to engage those patients again in a robust care program that says, did you get your medications filled? Do you have home health services? If you need those, did they show up if they were as we asked them to do? And do you know when your next appointment is? We continue to expand those programs, so we have 3 or 4 navigators in our hospital whose only job is to make those post-hospital discharge appointments, and we just recently trained all of our unit clerks on the inpatient side to do that, optimizing our medical records so that our patients actually know what that appointment is. When they leave, their discharge summary says your next 3 appointments are here, here, and here, so that they know where to go. So I do want you to know that some of that work is being done, and as we continue to invest in ambulatory services, that work continues to grow.
The private companies or JPS?
When you say private companies, what do you mean?
Meaning like it's Lorraine Miller Health Services.
So there are some home health companies that are owned by, they're private companies. JPS does not provide home health services.
Okay.
We contract in the community for those services.
Okay, great.
Okay.
Thank you.
Got another question? Yeah.
So as I look at JPS has three major revenue streams. When I look at that, I think that kind of helps me, and you can clear me up if I'm wrong. In the last meeting, which I was not at, but I was reviewing some of the notes, I saw where there were recommendations for the placement of certain centers throughout Tarrant County.
Right.
There are questions as to, well, why would we put a center here when the indigent population isn't so high? All right? So then when I looked at that the first time, I said, well, yeah, that's a logical question. You want to put the center where the indigent people are or where they're forecasted to be. So I thought about that. But now, when I see this, is this one of the reasons, or does this help to determine the placement of some of those centers then? Yes or no?
It's based on, and Sam was here talking about that and did the analysis, but based it off of some of our reports. So it is part of it is overall population growth, which is Medicare and elderly as well. So that was part of it. But given mission and focus and the large proportion of the population, the primary driver there in terms of absolute number of people and growth was on the indigent population.
Well, as a layman on the outside looking in, I noted on the charts from the last meeting that some of those centers wouldn't necessarily be placed. For example, we're talking about a 10-mile radius. All right. If you're in South Arlington, Mansfield, or other parts, Crowley, other parts of our county, 10 miles is 10 miles. Yeah. Without a bus,
yes, right.
Train, plane, you know what I'm saying?
Yeah.
It's still 10 miles. So then you would think, again, as a layman, without this information, that I would want to place those centers where those folks are. All right? Those people who can't get to it in the 10-mile radius based upon what the demographic studies say, and then the forecast.
Yep.
What they're forecasting where folks may be.
Yep.
And we do have pretty good forecasts in that regard. So then I was rationalizing, as I was talking it over even with our committee in Precinct 2, saying, well, yeah, that makes good sense. But then if I look at this, and I guess it's just, what's the real deal? I mean, and it's okay if you're saying, well, Pastor Evans, we put it in said area because we will need to have this kind of a mix in order to survive. I don't know.
That was not part of the weighting system to try to locate. Yeah, it wasn't yet to try to locate the health centers in a better payer mix or anything like that.
So
it was really focused on the population.
Well, let me follow up there.
Yeah.
So now with the question from our folks from Precinct 2 then, would be based upon those predictions or recommendations from the last meeting, then why would we not then have those centers right smack dab in the middle of where those folks are who can't get to them?
Yeah,
and that's for the record.
Yeah, absolutely, and no disagreement. And I think there definitely is an analysis there that's based on drive time that may not reflect the realities of some of the pieces on the ground.
Okay.
Greg, one other question real quick, and that I can't remember if this was in your tables last month or not, but tell me again where that breakdown of payer mix, where does that stand in relationship to the Bexar counties and Forest counties and Dallas County? Are we kind of in the middle there as far as our dependence on tax revenue? Are we high, are we low, or where do you think we are?
So staying steady, some are rising towards the bottom middle. So doing well if you look at a graph of those counties and kind of, if you see that in the report, the kind of where the bars are over the last few years and where you stand relative to others is quite good.
Yeah, so we're kind of in the middle?
Middle-ish, a little lower on the middle, yeah.
How about on the
And that's on
net-
the tax revenue.
How about on the net patient revenue? Pretty much.
As a percentage of
Yeah.
the total?
Yeah.
I don't know. Yeah,
Okay.
we can get that back to you.
Yeah. Be interesting to see how we kind of stack up on that too, just as a point of reference.
Yep, to others in
Yeah.
Texas.
Yeah.
Yeah, sure.
Wasn't there a graph or something you did in one of the other materials?
I believe that's in there. Lori and I, we have a bigger team behind us, no doubt about it. And Ray, who was here presenting that material, although, yeah, so.
Yeah, I knew there was a comparison. I thought it compared a different factor though
It
than this.
it wasn't exactly
Yeah.
this 43% and saying what that is across
Yeah.
other counties. So I think we'll just need to take a quick look.
Okay.
Do you have similar information, say, from Harris County?
Yeah, I think that's what Randy was asking for. Is there comparators that we can show besides the tax revenue piece, which is in there for sure? I'm not sure if this piece, as a comparator to other counties, is in there exactly as put on here. So.
Okay, any other questions? Thank you, Greg.
Thank you.
Appreciate it.
Thank you.
Yeah.
Maybe it's getting comfortable. I think we are comfortable now.
Nope. Candace.
Uh-oh.
I think we're contracted.
We can crank it up.
Oh, you got your jacket on, maybe it's just me.
It's all facility-based payments, so because everything is which actually does good with primary care. It does not do severe.
Candace, can you dial the condition, air condition?
Yes, I'll follow. She said turn it down.
All right, good afternoon. I am Patrick Chambers with the Cumming Corporation. I've spoken with you a few times, but it's been, I think, a few months, and we've been diligently digging into all of the project documentation and digging around at all the buildings over on the main campus and working up some information to talk to you about today. It's going to be a lot of numbers. I'm going to do my best to walk you through what all that means, but and I don't think this will be a problem with this group, but if you have any questions, do please stop me. And let me ask, and I'll do my best to explain. As GK talked about earlier, we were engaged to take a look at the existing project documentation that was put together, and it's a range of documents. Started in 2010 with a study, updated in 2014 with a study, and then in 2014 there was a document that I think was sent to you that talks about a bundle of projects on the main campus. So while Sam, the last two meetings, has talked more about the ambulatory network out in the community, this is going to be more focused on the inpatient environment on the main campus. One of our first steps was to help make sure we were comparing apples to apples, was to take the 2014 project, updated to 2017, looking at escalation over the last 3 years, updating those numbers, redoing the estimate, and we all have opinions, so we gave our opinion on the estimate. And then while we were doing that, we were on campus looking at all of the existing buildings to really determine their conditions and what will they be useful for. We had a very thorough MEP, and that reminds me as well, I'll get into some industry jargon, and if any of these things make sense to me but don't make sense to you, again, please ask. The MEP is mechanical, electrical, plumbing, which anymore is a major component of any hospital construction project. We looked at those existing conditions for the mechanical, electrical, plumbing, looked at the architectural existing conditions, looked at the elevators, seeing how those systems were and what their life capacity and lifespan was. Looked at the technology systems, also medical equipment, it's a big component of projects, and utilized all of that information to help formulate some recommendations, looking in the 2014 proposed construction project to see what of those components would be possible to deliver in a renovation setting, and what does that mean. So just to give you a lay of the land, this is the layout from that 2014 proposed construction projects. And we looked at really 3 discrete projects, or bundles of projects, if you will. The first one, which is the largest cost component, is the new inpatient bed tower, which is here, which also includes a new urgent care center adjacent to the emergency department, a central energy plant to support that expansion, and parking to also support that expansion. The second component, following movement of all those beds out of the tower, was going back in and doing some limited backfill in these areas in blue here. And then the third component, of course, is the new psychiatric hospital. So we'll start with the new inpatient tower. We wanted to look at what is the reason for new beds. As Greg and Lori have talked about, the current bed count is 409. Roughly 60% of those are semi-private. Based on the 2014 study, they developed a project that brought the total up to 496 beds, plus 2 empty shell floors with the ability to add another 120 beds. And what we mean by shell is we basically build the structure, enclose it, roof, everything, but all of the interior is empty. And so that's a common practice in hospital construction to go ahead and build that so that you have ease of future growth when you anticipate that you'll need that. And then again, based on what we talked with Greg about in their study, with the lower length of stay reduction, there's a 20-year bed need at 664 beds. So one of the other reasons that, it talks about goes to how hospitals function, and I think one of the things that those of us who were on the tour witnessed and heard is that there's a lot of inefficiencies and backups in the hospital. You come in to the emergency department, you have to sit in the waiting area because there's not a bay for them to admit you, to treat you in an emergency department bay, because there's a patient sitting there who's waiting for a bed, and they can't leave the emergency department to go to a bed, so it backs up all the way through. We heard the same thing about surgery. They have someone come in for surgery, have their surgery, go into recovery, lay in recovery waiting for a bed, and so that backs up, again, all the way through surgery to where the patient's waiting in the waiting room. So right-sizing these numbers helps improve that efficiency and flow through the hospital to keep those patients from having to sit in the waiting room. Another reason for the new beds is properly sized rooms. The rooms that exist now are woefully undersized, and we're talking about having bigger rooms so that you have, and we look at this concept of zones in the patient room. And we want to be able to create a zone for the caregiver, a zone for the family, a zone for the patient, and in this case, education, which drives a little bit of a bigger footprint for those patient rooms because it introduces more people into the room to do that education stuff. And then technology, making sure that we properly size the rooms so they can accommodate current and projected technologies. The other piece that was considered was moving to an all private room model. There's a number of reasons to do this. We've done several projects where they're moving out of the semi-private room to private. There are better patient outcomes, really follows best practices and industry standards across the country, improve patient satisfaction, and that's going to be a factor, or is a factor, in reimbursement. So improving that patient satisfaction factor and improved infection control, which we've seen some draft studies in place that talk about the actual cost reduction when you're able to improve the infection control within the hospital that comes from the private room versus the semi-private. So the next thing we looked at was, what is the condition of the existing tower, and can we renovate that existing tower in order to accommodate the acute care beds? I'll jump to the end here and say we do not believe that existing tower is suitable to accommodate inpatient care. And there's a variety of reasons that we've figured out during our investigations. The bed tower was built in the late 1960s, so it's quite an old building. The floor to floor, when I refer to floor to floor, it's basically from where my feet are on this floor to where the person's, maybe that's the roof, but the person's feet are below me. And in the existing acute care, it's roughly 11 feet. And what we're building now is 14 to 15 feet. And the reason that that's important is because there's a big component of patient beds or patient rooms that require air changes. They have to get air through those rooms, and that requires ductwork, big ductwork, and it's got to go above the ceiling. And so you've got to have the room to get all the ductwork and all of your other services above those ceilings, and 11 feet really gets to the point where you just simply don't have the room. One other issue with the bed tower is it's a very small footprint compared to what modern standards are, and you would really have a small bed unit. We're thinking 14 to 17 beds per floor. Where the current proposed project was 30. And we're looking at staffing ratios from nursing to patients, and those are in the 30 to 36 range, where those start to make the most sense. And if you remember the presentation a couple of weeks ago, I think the talk of the major component of GPS expenditures is staffing, paying for that. So we'd want to do everything we can to make that more efficient. And the existing MEP systems are significantly beyond their current projected lifespan. So if anything that you would have to do would be a complete replacement. So renovating that hospital, we did run some numbers on it just to look and see what we thought that might be. And so we came up with a cost of about $375 a square foot for renovation versus $410 for new. Now, on the surface, that new number is obviously bigger, and you multiply it out over square footage, you would think it'd be more money. But what we have found in doing analysis and studies of replace versus renovate is you're going to have an efficiency factor of about 15 to 25% in renovation versus new construction. So I would tell you our anticipation would be renovating that tower bed for bed would probably cost you as much, if not more, than an expansion. So, and then the other issue is that we wouldn't be able to maintain all of the new beds in one location if we did renovate that. So we'd still, just to meet capacity, would have to build new beds in another location, which maintains a major inefficiency that we've talked about with JPS that has 2 different bed towers that you're functioning and trying to staff and move patients back and forth in between.
Now, we determined there was asbestos in the
Oh,
tower,
yeah.
right? So that trying to renovate with asbestos is a whole different.
Oh, yeah.
Yeah.
So we can walk through some of the numbers at this point. So the way I worked through this is the 2014 cost estimate, and this is the bed tower. And keep in mind, so this assumes that all of the inpatient beds are moved to the east side of Main Street. So we vacate all of the existing beds that are on the west side of Main Street, all of the semi-private rooms, all the other rooms over there, move them over into new beds on the west side. The initial estimate in 2014 was $609 million, and that was based on doing the work, getting funding, and moving forward. So we have to, in order to be able to compare apples to apples, we have to account for the 3 years passage of time between that study and what we're doing now. And we have escalations roughly 6% or 5% per year for those 3 years. So that escalates that cost to $739 million, what it would be today. And this bundle includes the patient tower, all of the site work associated with that, the parking, and the energy plant to support that. So we took another look at that, did a new
Does that
estimate.
include financing costs as well?
Does not. That is project cost. It's a total project, everything short of financing costs. Yeah. So we updated our estimate and came up with an estimate of $706 million. It's slightly less. The difference was for going forward, we're looking at about 4% escalation, and that original estimate had 6%. So that really is talking about the difference. And we found that the numbers that was in the Blue Cottage report and in the proposed construction project were reasonable numbers, we thought, for construction. We did look at a couple of options. What can we do, or what do we think may need to be done differently based on our review of those existing reports, and also the work with HMA on what they were talking about. One of the things that we looked at and had a thought is, the patient rooms in that existing report were proposed to be 290 square feet, which are nice sized rooms, but our experience tells us if it's going to be an academic educational facility, we would recommend a little more square footage per room, just to allow that service to go on in there with the room, which sounds like a small amount of square footage, but when you amortize that out over 600 beds or some odd beds, it turns into a lot of square footage. So we've identified that it could be an additional $40 million in order to do that, and there's some other updates in the program based on some of the regulatory updates that have happened since 2014. One of HMA's recommendation was to complete the shell floor beds. The plan included 2 empty floors, so that would allow you to add another 120 beds, and we've estimated that at 64 million, which would get the bed count up to 616. And then we get to keep going here and talk about if we do go for the less aggressive length of stay reduction, then we're looking at 664 beds, which, fortunate for us, we're almost 60, so we can add another floor and cover those 60 beds, but that does come at a cost of an additional $44 million. So all of these numbers are going to be in our report, and there's going to be a lot of stuff here, so I know it can be a little bit confusing, but a lot of this is really setting up a menu for you. We're going to have our recommendations of what we think you should do, but it's setting up a menu so you can pick and choose, if you like, to figure out what the project, what your vision for that project will want to be as you make that recommendation going forward.
Patrick, if you get money in there, you're going to demo his recommendation to demo the existing tower.
We'll get to that.
Okay. So you got some money.
I've got money squirreled away from everything. All right. So we did also look at some potential cost savings options as we looked at some of the renovation options or reuse options. Some we thought were good, some we thought maybe not so good. The first one is maintain the existing materials management and laundry services, because that in the 2014 plan is included in the new tower. It's not a huge savings, but it certainly is not uncommon for those areas to be remote. But there are some issues with that, as those are, as you know, dated locations. Another we looked at, we did not recommend was keeping the food services department in its current location and renovating that. We just found that the cost savings was not substantial, and had a number of issues that went along with that. The limited space, again, maintains a remote operation of the food service. So the cost savings would be deteriorated quickly as an impact of those lost efficiencies. One item we did look at as part of our mechanical, electrical, plumbing review was the energy plants that are in place there now are somewhat siloed, and we figure that there's enough capacity if we're able to optimize those systems that we could eliminate a significant portion of the energy plant with this new project. So it would be a cost savings that we would recommend. One of the things we do recommend, however, and Greg alluded to this earlier, as part of next steps, we have all these bed numbers that we're looking at and just different components of that, is considering the methodology used in the 2014 study is a different methodology that Greg talked about, and it's based on 2013 numbers. So we would suggest updating that to 2016 numbers to have another look. When you start talking about these kind of dollars, we always think due diligence, a little more due diligence is warranted to do that study and update that and get a little better look at that. And also do that along with the ancillary needs for OR, imaging, emergency department, and other components of the hospital. Again, just a fresh look, making sure we're doing exactly what is necessary. The other option, based on these numbers, it's hard to imagine this would be one, but there are still inpatient services that are left on the east side of Main Street, namely observation and imaging. It would be an option to look at and think if you wanted to add that into the new tower and move all of that over onto the west side of my and backward to the east side of the tower, east side of Main Street. So again, just options to consider moving forward. So the next component was once that bed tower was empty, or once all of that was completed and everything moved over, we're looking at the renovation backfill. Again, using the 2014 cost estimate, escalating it to 2017, and then looking at our number. And again, this difference here is really primarily the different escalation factors from 6% to 4%, and this is more significant in this piece because this follows the bed tower, so it's farther out, so we have to apply that escalation factor for more years. So that would be construction in 2023 following the bed tower. One of the things we discovered as we were looking through this is the initial report indicated a significant amount of space would be left vacant in the new tower for future growth, but it didn't quantify it. So we went through and did some analysis and came up with 280,000 square feet of space that would be vacated as part of this move. Now, two of those are pretty discrete areas that may not necessarily have implication in what we'll be talking about, but the Trinity Springs building, which is the current Psych Hospital, is 64,000 square feet, and the laundry and materials management building is 36,000 square feet. Trinity Springs, and talking with JPS, they have a vision of using that for their IT department. So we think we can accommodate that. And the laundry and the materials management building, if we left that there, that wouldn't be vacated. We wouldn't have to worry about that. But even if we did move that over, that's pretty specialized space that probably not renovate well into any kind of function. So that left us with about 180,000 square feet of vacant space in that existing tower and those surrounding buildings. There's certainly plenty of options and thoughts and ideas of what could go in there. We looked at outpatient services, offices, psych services, or other ancillary uses. And again, one of the next steps that we would suggest is casting a bigger net around the entire JPS system, or really anybody that could use existing square footage, and doing some evaluation to figure out what are real potentials to fill that space. And one of the other items that there were two pieces of the project that were identified but not included in the proposed construction project that we would suggest taking a look at sooner rather than later is the specialty medical office building and the ambulatory surgery center on the existing campus.
And that's what an MOB is, medical office.
Medical office.
Okay.
Yes. Yeah, I try and make sure I cover those.
So you're saying one of the options would be to put the MOB in the old tower, anybody included in it, especially clinics and.
It's possible. It's so in the middle of the hospital. It's not done.
Okay.
But possibility. All right.
Patrick, I know the rules are on if you were to renovate the old tower, which we're not really looking at, but if we did, I know the rules are when you renovate, you have to go to the current standard. Does the same rule apply if you converted the old tower to non-hospital functions? Non-patient care functions. Do you have to go to the same? You have to do the same level of renovating that, or let's say it was that office space that we talked about, or can you go in and renovate without cleaning out all the asbestos and getting everything up to ADA and all the other expensive stuff? What's the rule on that?
It depends on the level of renovation that you go to. If you do enough renovation, if you touch enough pieces of that you have to get a building permit, you'll have to carry all of those requirements. And it's the asbestos is really an OSHA thing. If you're going to have workers in their building, we're going to have to take that asbestos out.
Okay, so if IT moved in over there to Trinity Springs, same thing?
It depends, and I think what the concept was that IT could move in there pretty much as it is. So if you're able to go into these spaces as is, then yeah, you wouldn't have to raise that up to current level of code.
And they think they could actually leave it alone?
Well, we think so for Trinity Springs.
Really?
There's an evaluation that has to be done. That's just one of many alternatives.
Yeah.
Patrick, correct me if I'm wrong, but you got to move the asbestos and demo it too.
Yeah.
Yeah, asbestos is an issue.
Oh, I know.
Certainly, it's
I know.
something, we actually have that it's in this number.
I just wanted to know what the reality is of actually moving some of these other non-inpatient services to these buildings, because if it really truly is going to be so expensive, we just need to know that. If that's just not really a likely possibility, then we just got to factor that in.
We have cost estimates for a variety of options to go into that renovated space.
Yeah.
So in previous conversations at the hospital, discussion came up about closing Main Street. I don't mean to be jumping the gun on anything else you might do. I haven't heard that mentioned yet.
It's an option. It's more of a detail that would be developed and worked through as the design came forward. I can tell you I've done a number of projects where we've closed streets, and I've done a number of projects where we tried to close streets and couldn't. I think there's a lot of due diligence that would have to happen with, I'm assuming that's a city street, that would have to work with the city of Fort Worth in order to gain backing to be able to close that street. We did an analysis, and we believe you could build that tower, without closing it, but it would certainly limit some of your flexibility. But that's, again, that's something that's a little more detailed planning, probably a next step idea.
So you have real estate that JPS owns on the east side of the building tower, without taking right away, without.
So I've refrained from talking about urgency. I'm going to say this once, and I won't ever say it again. Look at the money it's costing us as we wait. Construction costs have gone up. I'm amazed at how we're on the treadmill going nowhere. So for me, as a board representative here, all I want to say is either tell me soon that we're going to leave it just like it is and just cope, or let's make it better. Now, the other extreme to this is do what Dallas did, and that's go over on the hill where you have the real estate and build a whole new place. Am I quoting that wrong, GK? Isn't that kind of what Dallas did?
They did.
And nobody here has proposed that yet, and I'm not about to. So, but last time I'll say it, this group needs a sense of urgency, guys. We got to get this moving. Because I don't want to, a year from now, I don't want to be meeting with y'all saying, well, you know, construction costs are enough, another 25 million. What have we done? So, end of speech. I'm ready to get
Cumming, are you recommending that you're not recommending that we look at a totally new site? Because what
I would say that in Duck.
Yeah, I was going to say. Roy would say that as a former board member.
I mentioned that as a bad option. Well, talk to people in Dallas.
Well, I say that, and you tour the main campus, and it's so cumbersome to get around. So is it cheaper to keep her, or is it better to go and get a? I don't know that.
I think you know we haven't done. We're not. That's not part of looking at what we're doing. Is looking at a brand new campus versus the renovating. You have enough of an investment in that
We've
pavilion.
got the land.
You have enough of an investment in that pavilion and the emergency department that was made just 10 years ago.
Yeah.
Just trying to move it to precinct 1.
Without doing the analysis, I couldn't necessarily say, but it seems like that would make it seem like you'd want to keep that property, keep that location.
Yeah.
Well, and the rest of the issue, I do need to hush, I promise.
No, you don't.
But the rest of the issue is medicine becomes more competitive all the time. In case you haven't noticed, UT Southwestern has now opened a presence in Fort Worth with money donated from affluent people in Fort Worth. Some of that money, excuse me, could have gone towards the JPS thing. That's water under the bridge. But the children's hospitals, excuse me, are competing with each other right now in South Lake, in Fort Worth, in Dallas. So there's a competitive nature to this, and JPS maybe needs to catch fire a little more with the competitive side of, hey, we're in there.
I couldn't agree with you more.
Okay.
That's why
Okay.
I wanted to fast track
Yes,
this
sir.
thing from the beginning.
I got you.
But being more competitive means more money? Do we have to spend more, Scott?
Well, if you don't build it, they won't come.
If you don't build it, they won't
If you don't
come.
build it, they won't come. I can promise you that. That's
Yeah.
a movie phrase twisted. But yes, it's going to cost money.
Okay.
So the final component that we were talking about was the new Psych Tower, and that's located in this spot here, which is parking. So right now, our thoughts are that would follow the construction of the parking garage, you know, if we did that.
Let me ask you one other question too, just thinking about some of this discussion here. We're probably not going to be able to get everything we want, but is it your opinion that if we did build the new tower on that, I guess it'd be the east side of Maine there, is it your opinion that there's still enough available land for us to eventually get ancillaries over there so that we truly could have ourselves a completely efficient as well as up-to-date structure? In other words, if we had a plan, we're probably not going to be able to get it all now, but if we had a plan, could it be done, or is there not enough room over there on the old St. Joe's site?
I think you're limited to your inpatient services on that side and keep your it makes a lot of sense to keep your inpatient and outpatient separate. So keep your inpatient on that side and focus outpatient on the other side. I don't think there's enough room. There's not enough room to build everything over there and just.
There isn't. Okay. Okay. Yeah. So the thought then of us ever getting to what Roy was talking about, or GK or somebody about, we could do the Dallas thing. It's really not something that's possible.
Not on that.
Yeah.
On that location.
Okay.
And please don't quote me saying it was.
Or somebody, or wherever that idea was floating out there.
Somewhere.
Yeah. Okay.
So the other component that we looked at was the Psych Hospital, and again, the justification for this was looking at the current total of 96 beds in Trinity Springs. The 2014 study had a new hospital with 148 beds completed, plus 50 shell beds for a total of 198. And then the HMA study is suggesting 516 beds at 50% of the population. We didn't model a project on 516 beds, but we did look at the new project with the shell space completed. Some of the existing layout issues is obviously a limited bed count compared to what the projections are, an over-reliance on semi-private rooms. And as we walk through on our tour, we learned that often those rooms that are semi-private that are meant to house two can only house one, as often the patients are in such a state that they're not able to be commingled with other patients. So effectively dropping your capacity in half from where you stand. The service is fragmented and poorly located. The Psych ED and the intake is on the 10th floor of the old tower. So as you're bringing a psych patient in, you take them to the elevator, ride up 10 floors, and then have them evaluated there. And if they're going to be admitted, they go back to the elevator, down 11 floors to the basement, and do it through a long tunnel, and then back up into the Trinity Springs location, which certainly for those any patient would be suboptimal, but for agitated patients, that's a big issue.
I need to be on an awful lot of drugs to put up with it.
So, as we looked at the new Psych Tower, the 2014 estimate was $102 million. If we escalate that to 2017, that equates to $124 million. And our estimate is right on with that at $125 million for the new Psych Hospital. And one of the HMA recommendations was to go ahead and complete the shell space right away. And that adds, in addition to the 125, that's another $19 million to add that to that piece. And that's the construction in 2021 to 2023 in that time frame. And I forgot to mention that these construction timelines are built on an anticipated bond or fund, not bond necessarily, but funding determination in May of 2018. So a year to get that determined. You would launch into about a year of planning and design, and then have multiple phases of construction.
But you go back one slide.
Yes, sir.
But even at the 125, and then you need to add 19 to that, so that's 144. That'll give you 198 total beds at completion. You have more. You currently have 132 beds.
Yes, sir.
And they're not all in the same location, two different locations.
That's correct, sir.
So is the, I need to go back, but did you calculate in the beds that are not necessarily at Trinity Springs in this 198? Does that make sense? If you have 132 beds now, and you're going to build, and you say we need to have 198, so what you're looking at is 66 beds. So are you counting in that 198 the beds on the off-site location?
Patrick can correct me, but I believe the 198 would just be those that are on campus, on the main campus.
How many
to the extent
how many are off campus?
36. Those are leased beds, of course, so that lease would be independent of this program.
Where do we lease those?
They're on Rosedale.
So doesn't the question to be asked, if you're talking about 36 beds to the 198 beds, so what that gives you is 234 beds. And HMA is saying that you need 500 beds within the next 20-year period. But you have a gap here. You have a gap of 264 beds. So how do we get there? Well, should we not be, or should we be costing out the entire 500? Or should we be costing out only these, and then as we fill those up, build another facility? What type of efficiencies do you lose when you now have two facilities for psych rather than one larger facility?
Right.
And when you price this, we're talking about roughly double.
It's more than double, it's
So,
2.5.
so it's 2.5 times. Then if you take, and my math is going to get really bad, but it's going to be $350 million. That's what the number is.
Have you considered the existing capacity out there in the market within Tarrant County outside of JPS?
I think that was worked into the numbers that each may put
What is
together.
the number already?
Because really, it's 50% of 50%.
Yes.
Yeah.
Yeah. And that is coming from a literature-supported number of beds that's suggested by professional societies and, and not at a level, at 70 beds, that others are meeting either. So we should just be aware of that. That is a high number.
Doesn't the question...
That's the high number.
It's a high number.
It's a high estimate.
If you step back into the 35 rather than the 70,
yep.
And we're still saying that the 500 is 50% of that.
Right.
And the question becomes, if you really need to have a 50%, where are the other 500 beds? Is that something that the private sector can step forward and bring to the table? The nonprofits?
If there's money in it, they will.
Well,
That's the principle of the free market. We also have to look at it from this perspective.
We say that, Commissioner, but quite frankly, how many beds are out there now that the privates have brought to market?
Well, look at it from this perspective. JPS is, the legal mandate is to take care of the indigent population, right? The ratio that you are talking about is an overall total population. Okay, the total need of the whole 3 million people in 2037.
Correct.
Okay, so where do we find that balance? Are we building capacity enough for the 100% of the total population? Are we building it just enough for the indigent population within 250% FPL? Are we finding something in the middle? You see?
It's a good question. Then you also have to factor in the fact that, remember the 42 or 43% revenue that came from patient pay?
Right.
If you go all the way to indigent, that number goes pretty close to zero.
That's why I said it's a
And so-
fine
and
balance.
so-
You have to find a threshold.
And so if we do half the beds and expect the private sector to come up with the rest, then we have to make an assumption that the revenues that we generate for just the indigent population is going to be substantial less than that ratio that we see for the total operation of the hospital, because you're not going to have the payer mix.
That's what I said.
I mean, it's not easy to come up with this stuff.
It is not, right.
That's why we have the great minds around this table.
And one of the ways that we looked at it earlier, just so that it's out there, is by maintaining the current kind of level of commitment. I'm not saying that's right, but it's just one other way of kind of triangulating around what is the right thing to do. And there, that is 60 more beds than currently, so it's 132 plus 6, 192 beds. But that's keeping it at what is a very low level with what you see in the criminal justice system and other places where, the effects of not having an adequate public health psychiatric bed capacity is showing itself. So, but just as one piece to kind of understand, keeping the same level over time with the population growth would be somewhere around that 198, very close.
Yeah, Greg, there was a 200-something number in that number, because the 500-bed number was actually the
516.
literature, whatever, here's some recommended deals, nobody does that, right? Correct.
Yes, that's
And then you guys, our analysis, one of the consultants' analysis was, they came up with a whole different number, which was significantly less than that. It was more the recommended, based on trying to maintain the current level of service, or the current level of ratios, I guess.
Yeah.
Is that correct? I mean, and what was that number?
So the recommended number is still based on the literature and kind of going after the 50% and doing so 516.
516 is the recommended.
but then there is another number there, which is keeping current levels of commitment
What was that?
across a particular population there, and that is the 60 additional beds.
That's 26 versus the 50%.
It's much less than it's 6% of the overall need.
So one's 500 something beds and one's less than 200.
And I think there was just one
That's what we're
point.
talking about, right? One's more than 500 beds and one's less than 200 beds.
And that's not a recommendation, it's just a carrying forward of current.
And just one point of clarification, if I recall correctly from reading it, the 500 beds was the projected 30-year need. The 330-something beds that I think you might be referencing is the current need of that proportion of future service delivery, and the 200 beds is maintaining the current service delivery projected out.
I was looking for the 300 number.
Yes, sir. I had a feeling you might be.
Well, correct me if I'm wrong. If I'm wrong, correct me if I'm wrong, but there are at least 2 new behavioral health facilities coming up in Mansfield and in Arlington, currently right now under construction. Okay, so the market is responding to this. Okay, so just the total capacity that you are talking about, you have not taken into consideration the upcoming capacity that is under construction.
But that's on the private 50%
That's right.
side. We still have to be concerned about our 50% side, which is 516 beds in over a 30-year period of time, correct? Those new behavioral health facilities in Mansfield and Arlington are not going to serve the indigent.
So the 516 is 50% of the overall behavioral health needs.
Right.
So what you are saying here is we should build enough capacity into this new Psych Tower to accommodate that 50% capacity.
Correct.
So that means to do that, we have to add about 416 beds in addition to the 198, right? So you can take that 125 plus the 145 multiplied by 3 or so. Okay. And then you can add the additional cost for the ambulatory care that we talked about is critical in reducing the capacity and the bottleneck at the main campus.
Yep.
So in the end, we're going to have to weigh all the options and prioritize it because money doesn't grow on tree.
Just to say it's a 20-year projection, and that's why we recommended, that's why we recommended doing the behavioral health countywide plan, because it could be that some of these existing behavioral health hospitals and some of the up-and-coming ones might possibly take X%. You know, if they do it equitably among them, they might put a dent in the indigent care per se.
Where are you from?
No, I mean, if it's equitable, you know.
My query, I guess, is to the Blue Ribbon Committee. So, guys, I just kind of surmised from all of our discussions these last few months that we are really committed to trying to do something positive for behavioral health.
Yes.
And not just what it takes to keep us kind of balanced, but to now that we have a Trauma One center. I mean, we're gonna do something significant for behavioral health. I hope.
Yes,
I felt that,
yes.
But
yes, ma'am.
hearing this discussion, I'm kind of scared.
Yeah, I'm
and
feeling the
that's
same
what all the
thing,
constituents said too.
Yeah.
I'm feeling the same thing, but what I have learned in the past few weeks that we met, one of the statements that I think HMA made, which really struck me, was if JPS worked together with all the healthcare organizations and institutions in the Tarrant County, we would only be able to meet 75% of the total. Okay? So building additional building and capacity is part of the solution. A bigger piece of the solution It's some sort of a community collaborative effort.
Correct.
So when it comes to behavioral health, based on my study about Bear County and things that are happening around the country, the focus is not on additional capacity. The focus is on prevention
Yeah.
and the management on the front end,
Sure.
right?
Yeah.
So that right here, that piece right there is critical
Yeah.
to the overall solution.
I agree.
But we are not talking about that. We are talking about bond money,
Yeah.
you see. And I want to point that out to
Okay.
this committee.
The nature of the competitive business I talked about in medicine is, we are a level 1 trauma center. We're very proud of that. If you were so naive to sit in this room and not believe that at least one major health center in this town is developing towards a level 1 trauma center as we speak, I've got some land to show you in Florida near the ocean.
Yeah.
You are not going to find that competitive nature for indigent psych beds. You are not.
Yeah. That's all the more reason that we have to be proactive in doing something about it.
Okay.
Okay.
All right.
Good discussion, y'all.
Sure. One last little bit, and again, these are just some cost points that we wanted to make sure that we had out there, and this will be in our report, is looking at a couple of different demolition options. The first one is the cost to demolish the Trinity Springs building. We have that pegged at $3 million. That's a question. If that's going to be reused for IT, we can take that off the board. The materials management, the materials and laundry building demolition is $2 million, and if you did include materials management and laundry in the new building, we would recommend demolition of that building because it's not suitable for renovation for much. And then the big one is cost of demolishing the balance of the existing hospital buildings. That's $41 million. We have an allowance in there because we don't know really what, there's going to be a lot of bits and pieces that are left in that once we're done with once we would be done with the relocation from the expansion. So we have a $28 million allowance in there to consolidate everybody into a location so that you could come up with some demarcation lines and demolish some of that excess facility. So that's it.
Indulgence a little bit on your estimates, your methodology on the cost.
I'd have to talk to my estimators on that. We've got an estimating staff that does all that. We have a national database of costs that we use to develop our baseline estimate, and then adjust that to a location. But
you have some statistical variety. You've got a database with actual hospitals.
Yes, absolutely.
Adjusted for local construction materials.
Yep. Absolutely.
And then you're roughing that into some kind of square feet.
Yep.
I guess you include all your soft costs, but there's no real estate costs in there.
That's correct. That's correct. And in the report, there'll be the estimates will be in there, so you'll be able to see. It's a line by line, component by component estimate for the construction.
Did you put some contingencies in any of this?
Of course.
Okay, how much do you know?
10%.
10%? 10%?
That's a lot of contingency.
Any other questions?
Are you planning to come out with a final report?
Yes.
Including
Yes.
all your recommendations for the whole network, not just the main campus?
Yes.
It always takes longer and costs more.
So if I've got the schedule right, GK, the next one we have gets down to the fun part, right? Don't we start the fun part?
Sure.
Prioritization? Thanks, Patrick. So these next two meetings, I think, are going to be quite interesting.
To say the least.
It might be helpful if committee members can identify any topics that you want another deep dive into, or somebody to come and talk to us about a specific something that you, because you know what, I'm going to take this home again. I read it, and now that they've gotten up and we've had this discussion, I need to read it again so that it really, you brought some, through our discussions, we brought out some interesting topics. So are there other things that we've been,
I'd like to see some comparative analysis
okay,
among some of the ratios that were brought up in silo,
okay,
but there wasn't any comparison to other counties, similar counties, like 26% penetration rate into the indigent population.
okay.
The current there, you know, how are we doing in comparison to other counties? Without that reference, I don't think I'll be able to get much intelligence from that
Okay.
data.
Yeah.
I think also as we frame these questions, there's going to be a legitimate line of thinking that says, what is our capacity?
Yeah.
Relative to cost, what's our capacity based on our existing tax rate, based on the debt capacity that's reserved within the hospital system? And I would hope that at some point we're able to put forth some data that says, okay, these options equate to X on the tax rate. You know, JPS is not a system that issues debt very often. So by comparison, we have one of the lowest debt ratios of any public hospital in the country. And that creates for us a significant advantage in these discussions because it allows us to be able to consider these things without having to say all of these are going to cost gigantic tax increases. So some ability to frame that comparative financially may help us in the prioritization process.
Agreed. Agreed.
So I had one question, just being relatively new here, having
We're
left.
all new.
Pardon me?
We're all new.
We're all new, okay.
Newbies.
Newbies. So the one thing I haven't heard in my time here, and I only share this because where I just came from, this was embedded in the public hospital, and I'm looking for some of the things that can be distinguishing for this hospital, that the entire community, in addition to what the embrace already, and that's a burn center. And I ask that because I believe they're revenue generating, number one. They are iconic because, of course, if you need a burn center, you don't start shopping around to different. But I don't know where the nearest one is. I don't know how the state of Texas functions for a burn center.
Parkland.
So Parkland, so
Yeah.
we have one nearby.
I
So,
blew up.
okay,
Oh.
that's why I don't
I
hear.
gotta go all the way.
I know that.
Yeah.
My skin is sizzling and I have to go to Parkland.
Right.
Well, I mean, JPS gets burn victims now, but they ship
Yeah.
to Parkland, and I'm not saying, Stuart, that isn't a good idea, but that does require a whole nother analysis because we'd be going up against a very well
Right,
thought
no,
out
that's why I asked. I
burn
hadn't heard
center.
it, so I figured it had to be someplace.
Yeah.
And I just hadn't thought
Yeah.
to ask it outside of this committee.
Yeah, and then you've got the San Antonio burn center, you know, affiliated with the
Air Force Base.
the Air Force Base. Thank
Okay.
you. So I don't think there's a need from my perspective right off the bat, that's for sure. I'm not saying that we would never look into that, but I think right now it seems to be working pretty well for a JPS patient to get transferred, unless the JPS guys can tell me differently.
No, I would take it off the table. That was
Okay.
just a question I did
Yeah,
not
it's good.
have.
It's a good
If I
question.
know
Yeah,
Parkland.
yeah.
Does JPS pay for that if they have to be transferred on?
I'd like to see if we can get some help from our consultants and maybe even from JPS to maybe help us strategize these priorities, identify all these priorities, and put them into some sort of a strategic plan in terms of fulfilling the needs, in terms of reducing the admission to the hospital, and also in terms of generating revenue. You know, somehow we can find the right mix in terms of a strategy of when we implement which priority that will aid in the overall implementation of the entire solution. I would love to see a recommendation as such.
And with that, I would like to add some deadlines. Seems like that was a concern, is that we're going round and round, and although I agree it needs to be strategic, I think we're all in agreement with that. I'm also feeling a sense of urgency. And so I would just say I don't want us to cut corners. I want us to be mindful. So if there's a target deadline that we can try to set for ourselves, and therefore we're working toward that, because I know we want to move expeditiously on this.
GK, didn't we have something that was,
If you look at the meeting schedule,
So we're going to still stick to that with these additional, and this
Yeah,
additional-
I think we should stick with
Okay,
it, yeah.
as long as we stick to
Yeah.
the
one
plan.
of the
Okay.
things that we did today in court was we extended HMA's contract. so that they are going to help facilitate
Okay.
through this process.
Okay.
So we have some leadership from consulting. However, it's going to require that each of you, think through the issues that we've covered. And I know that it's been a big load.
Yes, it has.
But quite frankly, it's also been pretty much detailed in different bullet points. And to talk about and to try to think about what you think are important things to do and the timing of those particular issues. We're going to be working with some of the members of the committee here to help us produce a process, if you will, that will allow everyone to have some free thoughts on it and move forward to the point that we get where that we do make a recommendation, or the committee makes a recommendation to the court. I'm looking at the end of September to do that.
Okay, thank you.
So, but it
Well,
means
we've got a lot of work to do.
Oh, I
Sure
agree.
do.
Well, I've tried to attend every meeting thus far, and I think for me we're all citizens and working, this is a chunk out of my day, and I still salaried, I'm just a citizen, so want to ensure that I'm talking to my powers that be, that I'm taking time out of my work week to be here. Maybe even having to do, I don't think I'll have to do PTO or anything like that, but the point that I'm making is all of our time is extremely valuable, and I just want to make sure that September comes and that we're able to obviously think through everything, but maximize the time that we're here. That's all I ask.
Yeah, I like to add to that, based on my personal experience, which could be wrong, this process is kind of like pushing or pulling a thread, okay? If you try to push it, you're not going to go anywhere, okay? If we started pulling this thread back in 2014, we wouldn't be here right now, okay? So understanding the nature of what we are trying to do, we don't make the decision ultimately, it's the voters that make the decision.
Absolutely.
Right. So somehow we have to be patient, and then instead of telling people, we need to show the people and get them to buy in. Okay?
That's a good point.
It's
That's
very
a
critical
very
that,
good
yes,
point.
we wanted to meeting the deadlines, but we have to be very cognizant of the nature of what we do.
If I can couch that a little bit more, I agree, and as a taxpayer as well, I like to see the process go in motion if we have a need like the way we're talking about. So those hospital beds, those are important to me as well. And so if we aren't being deliberate, I'm not saying push things to be pushing things and pull things. That's beside the point. I think we're all here because we have a passion for our citizens. What I'm saying is that we have to move expeditiously, because what I also saw was cost rise as well as time went on. So I'm not saying do things just to be doing it. I'm asking that we set some milestones, and GK did clarify that. And so I'm looking forward to hitting that in September.
I want to go back to Dee's original question at the beginning of this meeting about the health status of our citizens. And I believe I said that raising the overall health status of the citizens of Tarrant County is not something that JPS can do by itself, all on its own. But we do play a significant role. We've got a statutory role to play in providing indigent health care to the citizens of Tarrant County. Now, there are two things at play here. One is our role our statutory role in providing indigent health care. How do we best do that? Where do we best do that? What kind of facilities do we need to do that? Where we're going to get the personnel to do that? Right. That's the charge of this committee, is to try to design that structure. But there's this other piece out here, which is the integrated healthcare system piece. And that's not directly the purview of this body, but it is the purview of Commissioners Court. And Andy and I talked about this a little earlier, about the court using its convening authority to get the rest of these institutions to the table and say, okay, here's our piece. Here's the rest of it. How are we going to work together as a community of healthcare providers to make sure that it all comes together and that the health status of our citizens is thereby raised? But we got to do our piece, and this is our piece.
Well, one of the questions I think when we first started, one of the things that seemed clear to me was that there had to be some coordination with the other healthcare providers. And I know, GK, we talked about it in meeting. I don't know if we ever got a clear sense of, yes, we are coordinating, but there's coordinating and there is moving forward. And so that to me is still a question in my mind. I know we're coordinating, we're having meetings, but what's the outcome?
Right.
Can we see the outcomes at this coordination so that if that were to, in my mind's eye, if that were the case, he wouldn't have such a behavioral problem, entity problem. You see, if there had really been genuine coordination.
Well, having lived on the other side of this equation,
I was just getting ready to say that.
and knowing many people that do live on that other side of the equation, and you guys can correct me. Maybe things have really changed in the last 12 months, but other than niceties and it's not like we're all throwing rocks at each other. I would say if 0 is no cooperation and 10 is fabulous cooperation, I'm not trying to sound too negative, but as far as real substantive, like let's figure out how we're going to do this service together. 2?
Pretty generous.
And he's not domestic.
Would we all be nice to each other? Well, of course we would. Would we still drink coffee together? Of course we would. Are we all interested in health care? Of course we are. Do we all want to take care of the patients the best we can? Of course. But when it's like what Roy said a little ways back, which is now you get into, I hate to say it, but the old dollar thing. And the only way that you're going to bring cooperative entities together that today are competitors is they're both going to have to see a mutual positive result. And those kind of dialogue...
it's not both. There's what?
What?
Well, the
parts.
public sector and then the multiple private sector.
Yeah, what I'm saying is, if
who's driven by
let's
profit?
say just
Not-for-profit.
it doesn't matter. It's irrelevant whether they're for-profit or non-profit.
Yeah, they have their interest.
They're only going to go into it if there is a decent return. That's just the life that we live in, and none of us can change that. Okay. So the only thing we can do is try to find mutual areas of interest where maybe both entities could benefit from that.
I think that's right, but what Commissioner Brooks, I think, is the broader issue is there's citizens out there that have to believe in this program, and if we don't have that goal of whatever the health status increasing, and then you've articulated it well, then I don't think we can I don't want to go through all this process and then have the whole thing shoot down by the voters. And I think we have to build a consensus.
Yeah, I just don't think you're going to do it by...
Whether they're going to do it or not, you still have to have that as a...
I was addressing the question of, are we currently working with the other providers to address some of these needs? And I would say that that's probably not going to happen.
I would say that has not yet happened.
And it's going to be a long road. That's a long, long road.
Commissioners Court and Public Health, which Andy described as Switzerland.
What, Commissioners Court?
No.
Public health. So we just went through this.
But there is an incentive, Randy, And that is that not-for-profits have an obligation to do what is called charity care up to the value that they get from their billions of dollars worth of real estate not being on the tax roll. Now, that is something that none of the not-for-profits have ever stepped up to in a concerted way. They want to call bad debt charity care. Well, bad debt isn't charity care. Bad debt is bad debt. Charity care is intentional.
Right, absolutely.
Yeah.
But you know, Stuart was about to say something, and I think Stuart may be one of the keys to this puzzle. Pardon me for referring to you, but
Okay, now the pressure's
We want
on.
him to stay with us.
no, we're friends. We're friends. I'm not against you. But one of the hooks to this whole collaboration thing is academics and education. I promise you, we need more medical specialties trained. We need more primary care docs, and education is key. And that's how the hook.
Yeah, what I was going to share is, so I went through this with an excellent partner, which I fully expect JPS to be, Public Hospital. $1 billion bond, passed in a very comparable county to this by 60-some%, but that's not why I'm saying that. And we're going to go visit them, I believe, to see how this played out. But here's what happened with all of the not-for-profits. At initial discussion, they would be supportive. As it got closer to the bond vote, they actually, behind the scenes, started to campaign against it. And they took an absolute neutral stance in the public eye. And it was very clear why. So they need, I guess probably in any county, they need the public hospital to be open. They can't afford to have it close and just board up. But the converse, they never want to have you competing with them. So there's, and it's such a fine line in their eyes. So, I'm sitting here listening to this conversation, and we're all thinking and saying the same thing. We may prioritize a little bit. I'm pretty amazed that in a 3-hour meeting, and it wasn't set up this way, we literally did not talk about the ambulatory care side. We just put $1 billion+ on the table. And I'm not being critical of it, so don't misinterpret. But we're all talking about keeping patients out of hospitals. And the reason we're having to do this is we have a 50-year-old infrastructure. Not if it were a 10-year-old, we wouldn't be having this conversation. We would be looking at the ambulatory care. So unfortunately, I was hoping to hear something different when it was asked. Or if the Commissioner's Court can somehow twist arms where it really hurts. It's not just, a little ouchy. Otherwise, they're not going to buy into the mental health, which is consuming, and we all know, I don't need to say what it's consuming, society and care, police care. Yeah. If I come with an insurance card, if one of my family needs to be put in, they'll be all over me, but they won't be for everyone else. So I'm kind of like with Randy, I don't think they're going to get there in the near future unless we have something to just really hold over their head. I don't know what
It's not something I would love to see that.
Right.
I really would.
Right.
I would absolutely love it. And it's probably one of the biggest frustrations I had in my career was how we were all siloized and we would never work together on anything. But it wasn't just here. This is the way it is in almost every city. I just didn't want this committee to start chasing that down as a potential hope anywhere in the near future. And I think right now our priorities are, not to put too much of my opinion on this, but you've seen it. We know where the major holes are. We're just trying to decide now how big, how much of it can we do. I mean, is there anybody that's going to argue that we need to help the behavioral situation? Which, by the way, that's probably the only place that we may get some support from our competitors. And let me tell you why. There are behavioral patients sitting in every ER right now in the Metroplex that can't get to JPS because JPS is full. And they take care of, in their limited ways, behavioral patients because there's just no choice. And so they have untrained people doing the best they can in an area that they're not familiar with. So that's one area that they're probably going to be waving the flag for you guys and saying, you bet, let's get that JPS capacity. Now, do they have selfish motives behind it? Yes, they do, but that's not relevant. We can't deal with that. We can only deal with what we've got now. And we know there's some significant holes that we can really improve care, which ultimately is going to improve care in this community. I'm like you, Stuart. I think it's coming. No pun intended. I just thought of that. I think, though, in your final report, you are going to show some reports about how much it's going to cost for us to do some high priority
So can I address that to a certain
ambulatory,
extent?
right?
Yeah, the clinics.
The clinics, yes.
The major medical homes.
Yeah, that's coming.
Yes, you might remember that when Sam made his presentation,
2 weeks
he identified at least 4 new medical homes. And these are full-service medical homes that have not, and it's very similar to what we're doing in the Northeast right now, where you have not only
They'll include pharmacy.
medical care, but you also have mental health care and things such as that. And rather than taking an abstract pricing on something like that, we're building those right now, so we know what those prices are. And those prices are, we've run the numbers for a 3 to 5 year period with an escalation of 5%.
I think we ultimately landed on 4%.
4%. And those units run about $21 million apiece. Okay? So you can do the math very quickly, and you're looking at somewhere around $84 million. And that's going to be included in the final report. We didn't have it in this one, but that doesn't mean.
No, and I wasn't saying.
No, I understand that. We understand how critical it is to keep people out of the downtown campus.
Yeah.
But now, Randy, that goes back to the question I asked about an hour and a half ago. And that question was in regard to that very thing. What GK is talking about is what matrix are we using to determine where we put those? Was my question in that regard. That very thing. So, and even going back to public support, you're right. If the other people in the county don't see a direct benefit where they are, they're not going to support it. And that's an issue. The transportation piece, which requires partnership between the county and the cities, and that's just fair. We just have to state that, and lay that out there. But yeah, I mean, if we don't show that we care about John Q. Public, I'm telling you, in Crowley, Mansfield, parts of Arlington, then you're going to have pushback. It's just going to happen. Whether we like that or not. It's a reality.
We recognize that.
Yeah, it's a
And
reality.
so the question becomes, what do we do about that so that people
Exactly.
feel that they have a buy-in? We've had our public forums already, but I think we're going to have to really be thinking about how do we get this message out to people in a way.
These guys are that covered.
Y'all got it covered?
It's Diane Placo's job.
We
She
always
runs
like
the
to
clinic.
divert the staff, okay? But it's a serious
Calling
question.
the messaging.
Yeah.
Support
Stuart,
this bond issue, or these people will be in your hospital emergency room.
Stuart, how did the
us
messaging go in Phoenix where it was, 60% is a significant.
Unbelievable.
Yeah, what was there anything special they did out there?
We're going to go and see the marketing firm and see what they did. They did something very special. I think the public hospital was viewed very similar to here. It's not a different demographic in many ways. Affluent areas, very underserved areas. But I don't know what the magic was. I was really shocked when they came out with their first estimates. and they were high, but doggone it, the vote came in. So the community does support, as a tax district, actually, their public hospital.
Yeah.
But the not-for-profits, the other thing I was going to say is, if you don't know any better and you go to one of their CEOs and you say, oh, what a great thing my public hospital does, the next comment back to you was, well, we care for more indigent than they do. And if you don't know any better, that could be an editorial in the local newspaper.
Yeah.
And the community's gonna say, well, why are we so supportive of this public hospital when, and I'm not gonna comment on the hospitals here because I'm working with them and I don't know the community, but I am telling you back where I just came from, every one of them, that was their comment. It was kind of like, no, that public hospital is pitching you a bill of goods. We actually take care of more. And then it goes to the charity care issue. And it kind of just cuts you off at the knees when you're trying to get them to be a player with the public hospital.
Yeah. Yeah. That's actually my biggest fear out of this whole thing. I know we're going to come up with a good recommendation. I really do. I mean, we're going to prioritize this, and I know we're going to have a great plan. But this communication to these people that are outside the immediate Fort Worth area, that's my biggest fear, is how can I get them bought into this?
Yeah.
Well, Randy,
I'm not saying it can't be done.
Since you come from that world, I think I'm going to appoint you to be the diplomat in charge.
Diplomat in charge. Sure.
But we have been talking about this
since
the beginning. The communications, no matter all the work that Cummings and HMA do, if we don't communicate this effectively, where people feel that they've got a stake in this. As my mother say, you're in woo-woo land. Yeah.
Well, I would take it as my personal responsibility to communicate with the hospital CEOs and board members within my precinct. It's tough, but at least we'll give it a try.
Yeah.
Okay, we'll see how that goes.
Okay. Anything else?
Move to adjourn.
Okay, there you go.
When's our next meeting, Ken?
It is July. Oh, sorry.
This was?
Yes. June 20th.
See you.